manifestation of this patient's disease symptoms, they will vary greatly from a simple chronic bronchitis without any disability whatsoever to a chronic respiratory failure and severe disability where the patient is stuck with oxygen on, can't really get out and do anything, is basically bed bound. So everything along that path is a possibility. The manifestations are typically mild or absent early on in the disease. You can have a chronic cough with sputum production and early initial dyspnea only in cases where the patient is exerting themselves. With chronic bronchitis, you'll see that they have a cough that produces copious amounts of very thick, tenacious sputum. And then they'll get to the point where there's some cyanosis. Then there's evidence of right-sided heart failure. There are adventitious lung sounds prominent when you auscultate. The patient with emphysema, it's more insidious. It's not as noticeable. So they will have some dyspnea with exertion. They'll have a minimal cough. They will start to develop that barrel chest through the years over a long period of time due to the air trapping and the hyperinflation of the alveoli and of the lungs themselves. Their breath sounds will become more diminished, and they'll start with the pursed-lipped breathing as a compensatory mechanism. These patients, again, are often thin and tachypnic. They use their accessory muscles. They assume that tripod position. And then with both, there's prolonged impairment of gas exchange, which will eventually result in a cardiac dysfunction. And then the patient will need to be seen at least every 6 months once they've been diagnosed with COPD to keep an eye on how they're progressing with their disease and the management of that disease. The caloric demand increases greatly because there is such an effort in order to breathe. So as the work of breathing increases, the caloric demand also increases. Anxiety levels also increase with these patients. This slide looks at the classification of COPD. And so basically for this class, what you need to know is that it goes from stage 1 mild to stage 4 very severe. It's based on a combination of the patient's symptomatology and how well they perform on pulmonary function tests. So the big test that we look at is the forced expiratory volume, or FEV. And what is that? That is the volume of air that they can actually force out after taking a good deep breath. It's an important measure of their pulmonary function. And then the FEV1 is the amount of air that they can force out in 1 second. And so you look at that combined with the symptoms that the patient is having. Are they sick all the time? Are they sick 50% of the time? Do they present with very severe symptoms? Do they have right-sided heart failure already, signs of that have developed? And if so, then they're going to be further down in the categories. I'm not going to test you on is this patient, stage 1 or stage 4. Looking at diagnostic tests that we will perform on a typical respiratory patient to see whether they have COPD or to diagnose what is going on with them. The PFTs, or pulmonary function tests, these are tests that are designed to measure how well the lungs are working. And they gauge how the lungs expand and contract when the person inhales and exhales, and they measure the efficiency of the oxygen exchange with carbon dioxide between the blood and the air within the lungs. Then we have the VQ scan, or ventilation perfusion lung scans, and that is used to examine the circulation of air and blood within the patient's lungs. The scan requires using 2 different nuclear tests, and so the 2 medical isotopes are used to detect the flow of breathing or ventilation and blood circulation or perfusion in the lungs. Having these scans performed will require that a patient either inhale or have an injected radioactive material or radioactive isotope so that ventilation and perfusion can be detected and analyzed on the scans. why is this scan performed? Typically, it's done to test for the presence of blood clots for a patient that had a DVT and you suspect it's gone to the lung, for instance, or if there's another abnormality in ventilation and circulation in the lung. It's also used, though, in the presentation of COPD patients or in pneumonia. The serum A1 antitrypsin level, that is a blood sample that's taken, and so alpha 1 antitrypsin, or AAT, is a protein that's in the blood that protects the lungs from damage that can be caused by activated enzymes. And so this test measures the level of the AAT in the blood. The AAT helps to inactivate a lot of the enzymes, the most important of which is elastase. And elastase is an enzyme that's produced by the white blood cells or neutrophils, and it's part of the body's normal response to injury and inflammation. This elastase will break down proteins so that they can be removed and recycled in the body. If it is not regulated, though, by AAT, elastase also will begin to break down and damage lung tissue. So you can see how it's important to have a good level on what is happening with this. Basically, what you need to know for that is just that the serum A antitrypsin level is a blood sample that is taken, and that it measures the level within the body of the AAT, which is important in enzyme regulation. ABG levels, arterial blood gases, hopefully you know about them from the earlier lecture. Pulse oximetry, where we look at the saturation. The exhaled carbon dioxide levels, the CBC with WBC and WBC differential. So we look at the complete blood count, look whether the patient has an elevation in their white blood cell level, and look at the differential of that or the breakdown of that. And then the chest x-ray, and we talked about how important that is, for instance, with the emphysema patient. We want to briefly look at the pharmacologic therapy for COPD patients. One thing that's very important preventatively, and the big thing here is prevention with the COPD patient, but not only preventatively, but once they've been diagnosed with COPD, immunizations are key. These patients, if they develop the flu, are in a much worse condition than the person who develops the flu who has otherwise healthy lung status. So this person can get a simple flu and within just a very few days can be in a complete respiratory distress. Antibiotics, if infection is, and it's not just the flu, I should say, it's also pneumonia, all of those immunizations should be kept up to date. Antibiotics, if the patient does have an infection, and I would caution here, not everyone who has a respiratory illness or respiratory congestion needs an antibiotic. But if the patient does have a bacterial infection, then they need to have an antibiotic to get them through that. Some physicians feel that if a patient has a history of COPD, it's better to err on the side of caution and get them an antibiotic on board. If we find out it's not bacterial, you can always discontinue it. Bronchodilators, remember how the bronchus, particularly in the patient who has the chronic bronchitis, but in either case, if the bronchus is being constricted, a bronchodilator can make a big difference in how well that patient is breathing. Corticosteroids also to cut back on the edema and get the patient's respiratory status improved. And then there's research also indicating that statins may be helpful with the patient who has COPD. Last of all, last but not least, is the option of surgery. So for a patient who has severe COPD, end-stage COPD, there is the option of lung transplant or lung reduction, the reduction of the diseased portion of the lung so that there is more room for expansion of the healthy lung tissue. However, this patient generally needs to be a person who is meets very specific criteria. one of which is that they no longer smoke. The incidence of rejection of a transplant, actually of any kind, but in this case of the lung, for a person who smokes is much, much higher, and so generally they're not considered for transplant. In addition to using pharmacologic therapy, oxygen therapy is obviously very important and an integral part of the treatment of a patient with COPD. Early on, the big benefits are that it improves exercise tolerance, and you do want these patients to exercise. You want them to start slowly and begin to build their tolerance for exercise so that they can do more and more rather than doing less and less. The more active that they are, the more active they will stay. A patient who just sits in the chair and lets the disease take them will be taken by the disease very quickly. Mental functioning is improved. The more oxygen, the more perfusing that happens with your brain, the more cognizant you are, and the better mental function you have. It improves the patient's overall health status, so there's a reduced rate of hospitalization. The patient is able to be at home more, or at work more, or at life more, rather than being a patient. Oxygen therapy also often is used intermittently in the beginning. Often the patient will use it at night continuously and then intermittently during the day. Over time, it becomes better for the patient to use the oxygen pretty much all the time so that they can decrease the work of breathing and decrease the workload of the heart. It is used with the patient regardless of the fact that they have COPD, and it is used even in those patients who have a chronically elevated CO2 level. You will hear nurses, as you start your clinical rotations, who are very hesitant to put oxygen on a COPD patient, or they will say, don't give them very much, or make sure that they are not higher than 2. And that was for many, many years the thought. You don't give a patient oxygen, or you give them only up to 2 liters if they have COPD. We do still not give them high levels of oxygen usually, but we do give them oxygen. Okay. So other therapies, as we continue on, percussion, vibration, and postural drainage, and these are generally performed by the respiratory therapist. And so percussion is when the therapist takes their hands and puts that in sort of a cupping position, and they cup their hands and clap them on the chest and or on the back, wherever the areas of the thickened secretions are. And doing this makes the mucus easier to expel or cough up. So often after they've gone in and worked on a patient and they come back out, then that patient's going to sound worse than ever. And as you're going past the room, and you'll hear the patient coughing and coughing and coughing, and the patient will say, I feel like I'm worse when the therapist comes in. And so we have to reinforce that that's the purpose of the therapy, is to help them to bring up those secretions. It sounds very much like a horse clopping in the room when they're banging on or percussing the patient's back. The next is vibration. The caregiver places their flat hand firmly against the chest wall and puts it on top of the segment of the lung that they're trying to drain. And then they stiffen their arm and their shoulder and apply light pressure. And it makes a shaking movement, much like a vibrating device. And the patient then should be instructed to breathe in deeply during that vibration therapy and exhale slowly and completely. And by taking deep breaths and then exhaling slowly and forcefully, but without straining, it helps to stimulate, again, a productive cough. And last, they'll do postural drainage. So after they have completed the percussion or vibration or combination of the two, or just after a respiratory treatment, breathing treatment, they will place the patient in a position where they can drain the sections of their lungs that are the most affected. So they may be placed in a variety of different positions, and they'll be in that position for a certain amount of time, and then they'll come in and move them to another position. And it just depends which areas of their lungs most need draining. Collaborative efforts. Other interventions that we're going to go through are smoking cessation. If the patient is a smoker, or if there's another smoker in the house who is willing and interested in quitting, then we can get them together with a smoking cessation clinic. Avoid exposure to other airway irritants or allergens if at all possible. Pulmonary hygiene measures, exercise, hydration, humidifiers. Improve, again, their exercise tolerance and enhance their ability to be able to perform their own ADLs. We truly get some patients in who are so debilitated by their disease process by the time they come in that there's very little that we can do to help them. So today, the focus of healthcare is much more on maintaining and preventing problems within health. So we want to make sure that we're catching them earlier and that we're teaching them better and preventing the deterioration of their overall physical condition. Other therapies that are important. Dietary is very important because the dietitian can work with these patients. If you remember, we said earlier on, or I said earlier on, that these patients tend to need a much higher calorie intake. And yet these patients have difficulty eating a full meal because they are so short of breath. And so what we need to encourage them to do is eat frequent, smaller meals. And we need to encourage them to use things such as Ensure to supplement their meal intake. We need to talk to them about high calorie and high protein intake. Also, some people get a really nice effect from acupuncture and hypnotherapy, especially with the anxiety component to this disorder. Looking now